Good morning, everyone. My name is Karen Perlman. I'm one of the rabbis here at Congregation B'nai Jeshurun, and it's such a pleasure to see all of you this morning. We were a little bit nervous about the weather going into this week, but clearly the gods, or the God, was on our side, and we have we not only missed the storm, but we all get to be here this morning. I'm going to introduce our moderator and say a couple of things, but I've always believed that if there's something that you're talking about with your spouse, or something you're talking about with your therapist, or something you're talking about with your doctor, or something you're talking about with your girlfriends over coffee, this is something you should be talking about in your synagogue, and that our synagogue shouldn't just be a place where we pray or we study or we're with our kids, but our synagogue should be a place where we really talk about the tough issues of the day, and we don't get scared away by the possibilities, and we actually sit together and talk about things, issues in our community. And that's why an event and a morning like this really makes me so happy and so proud to be a rabbi of this community, because we are coming together to talk about one of the scary and really challenging issues of our time, and that is the connection between genetic risk factors in our Jewish community, our Ashkenazi Jewish community, and the possibility of different cancers. So this is a morning not about fear, but about education, and I'm really, I want to thank all of you for being here, and I really look forward to a wonderful morning. Before I introduce our moderator, I just want to say thank you to the co-presidents of our Women's Association, Jen Beagleson and Julie Cohn, for their support, and for Michelle Kaplan and her family for really getting this ball rolling and really being patient as we brought it to fruition. And finally to Debbie Klein, who really has put a lot of time and effort into this morning. So let's thank all of them, for they really made it happen. You're going to find out who our panelists are, but I first want to introduce our moderator. She may not be unfamiliar to you. Her name is Dr. Nancy Simpkins. She is a board-certified internist and medical consultant for the state of New Jersey. Her practice is in Livingston, New Jersey. She has been involved in all aspects of internal medicine with a focus on women's health. Known for her diagnostic ability coupled with her wit, Dr. Simpkins has garnered a huge following and become a sought-after speaker, guest, and consultant for women's groups. She is dedicated to raising awareness by providing the most current and up-to-date information that women at any age can utilize to feel and look their best. And she is going to be telling you about our program and introducing you to our panelists. Dr. Simpkins.
Thank you, Karen. Good morning, everyone. I assume you can hear me. That's not usually a problem that I have. But anyway, I don't really know how to use this. This is my husband's territory, the microphone. Not mine, but I'll do the best I can. So good morning, and thank you for joining us this morning. So as we all know, breast cancer is the #1 concern of all women. It's funny because about 600,000 people will die of heart disease this year, and 40,000 women will die of breast cancer. But if you ask any woman in my practice, what is your biggest fear? They will tell you that I will die of breast cancer. So because of that, we need to address all of these issues. So I thought I would start off with just a quick story about a patient of mine, a beautiful 21-year-old college student who lost her mother at the age of 32 from metastatic breast cancer. And she came to me as a new patient at the age of 21, and she said, quote, "Dr. Simpkins, I do not want to die like my mother. What do I do?" So I, as the scientist, internist, Western trained, thought in my head, well, just take everything out. Take your ovaries, take your uterus, take your breasts off. And then I looked at this beautiful child who hasn't even started her life yet. And I thought, this is not for me to decide. I don't have the facts. So enter a panel like ours this morning who are going to separate fact from theory and fiction and help many people, including a young patient like mine, to make the best educated decision for her individual situation. So these distinguished, brilliant women who sit to my right will help us with a young patient saying, does she carry the Baraka gene mutation? Is that all that matters? How do we decide about this specific patient's risk? We will explore many scenarios like this one. We are privileged to have this panel chaired by Dr. Susan Domchek, a medical oncologist who is the Vassar Professor of Medicine at the University of Pennsylvania and Executive Director of Vassar Research Center for Baraka. Joining her is Amanda Brandt, a board-certified genetic counselor at University of Pennsylvania Abramson Cancer Center. And in addition, we have Daniele Nodelman, known to many of you, who is a carrier of the BRCA1 mutation, and she will share with us her personal insights and knowledge. They will all help us to understand the hereditary cancer risk within the Jewish population. I urge you during the program to write down any questions or thoughts that you might have so that we don't interrupt the flow of the program, and I promise I will allow you plenty of time to either hand in questions or stand up with a microphone and ask your specific questions. So let us get through ours first. And before I start with my questions, I just want to give a shout out to our local breast centers that are here. I mean, with all due respect to all our Penn people, our local hospitals are here. I think Overlook and Morristown are represented, and I know Rosemary Scarpatulo from the Breast Center at St. Barnabas. Rosemary, raise your hand. Afterwards, if anybody has any local questions that we could help you with, she's our girl. Sorry, but that's my hospital. I got to give a shout out. Okay, let's get started. Let's start with Dr. Domchek. Maybe you can tell us some of the key pieces of information that we should all know about Baraka and the associated cancer risks.
So just to start off, there are two genes, BRCA1 and BRCA2, and they stand for breast cancer 1 and breast cancer 2 because we're not really that creative. So that's how they got their names. And they were the first two genes that were discovered that were linked to a high risk of breast cancer and also ovarian cancers. So these two genes everyone has, and when they function normally, they help repair DNA damage that occurs in the cell. So everyone's got it. So sometimes we hear people say, I've got the BRCA gene. No, everybody has the BRCA1 and 2 genes. What can happen, though, is if you're born with one bad copy of BRCA1 or BRCA2, that significantly increases your chances of developing breast or ovarian cancer, and less so other cancers, as we'll discuss later. And these risks can be very, very significant. For BRCA1, the lifetime risk of breast cancer can be as high as 60 to 75%. The risk of ovarian cancer can be as high as 40 to 60%. Those risks are somewhat less for BRCA2, with the risk of ovarian cancer there being 10 to 20%, but these are still massively elevated risks compared to the general population. And so it's very valuable to have this information, to know about it so you can make informed decisions, and we'll talk about that a little bit more. One of the reasons that we're here today is because these gene mutations are overrepresented in the Ashkenazi Jewish population. So they're much more common, and for every 40 women or 40 individuals, women or men, who are of Ashkenazi Jewish descent, 1 in 40 carries one of these mutations.
Okay, so can you tell us a little bit about why the studies have shown that they're more common in Ashkenazi Jews?
Yeah, so this is, there is a whole sort of field of genetic epidemiology to kind of explain why founder mutations exist. That's what we're talking about here. Is it's not only that 1 in 40 individuals of Ashkenazi descent has a mutation. And by the way, I say it like that because people can be Catholic or Presbyterian or atheist, but have Jewish ancestry. So this is about having Jewish ancestry, not, if you will, you're currently practicing religion. It has nothing to do with your religion. This is an ethnicity question. So it's not only that they're more common, but there's really 3 main mutations that most people of Jewish descent have. The vast majority, 90 to 95% of the time, if you are of Jewish descent and have a gene mutation, it's in one of 3 spots. And the way we think of this is if you have a really big book, you have 3 spelling errors and you know the 3 pages they're on. So you don't have to go through and spell check the whole book. You can look at 3 specific pages. But why did that happen in the first place? And this is where it gets into this population genetics concept of bottlenecks, which is at some time a larger population became a smaller population, And in that smaller population now, these gene mutations persisted. So when the population expanded again, they were overrepresented. And I'm sure you all can think of through history times when the Jewish population has undergone bottlenecks and sudden decreases in population. So it's actually history meets genetics, and that's sort of why there's overrepresentation. There's other communities in which this is true too, including Iceland, where there's one gene mutation basically in all of Iceland. So it's not, the concept of founder mutations are not unique to the Jewish population, but they're the most well known.
Thank you, Dr. Domchek, for that very uplifting news for most of us in this room. But, Amanda, maybe you can tell us what are the current recommendations for Baraka testing and how it's done.
All right. Well, thank you all for having me here today. When I meet with patients and families, one of the main things I look at, in addition to Ashkenazi Jewish ancestry, it's a question that I ask every patient, as in anyone with breast cancer who's Ashkenazi Jewish, anyone with ovarian cancer are automatically recommended for BRCA testing regardless of additional family history. For individuals of non-Ashkenazi Jewish descent, I look at the number of women in the family who have had either breast or ovarian cancers. I look at the ages of onset of people in the family. So were women with breast cancer very young, under 50, who were premenopausal with their breast cancer, or were they a little bit older in their 70s or 80s with their breast cancer? So the younger the woman is, the more concerned I am of a BRCA mutation. We will also look at the father side of the family. These gene mutations are not sex specific, so we can see both coming from the mother or the father side of the family. So it's important for me to be able to look at the father side. If maybe there's not a lot of women on dad's side, it might be masked that there's a mutation there and why it hasn't been represented if there's only men on that side of the family. So I use a few key tools when looking at family history to assess. If someone's unaffected, who's Ashkenazi Jewish with a family history, it's also an indication for me to consider some testing. And if you look in your brochure, there's actually a section there on the right-hand side with some recommendations of who can consider genetic counseling and testing, but we use family history as a key.
Thank you, Amanda. So now we turn to Danny and say, now that we understand about the genetic testing, tell us a little bit about why and how you decided to undergo your testing.
For me, it was all about family history. My dear Aunt Marcy was diagnosed with primary peritoneal cancer, which is cancer of the abdomen, the lining of the abdomen, and she tested positive for the BRCA1 mutation, and she implored my sisters and me to get tested. At the time, I didn't know this, but she told me that 5 of my great aunts all died in their early 40s from either breast or ovarian cancer. These were my dad's aunts. So we did have a very strong history, so my sisters and I decided to go get tested. And I went to the genetic counselor. I had counseling with one of my sisters. Really didn't think anything of it. Didn't faze me at the time. I didn't really know too much about BRCA. And 2 weeks went by. Actually, I was more fearful of the needle than I was of the result. And 2 weeks went by, and it's kind of one of those momentous occasions in your life where you remember exactly where you were when you found out something happened. And for me, I was in Short Hills at my sister's house. I was home. I went to my sister's house from work for a work lunch one afternoon, and I got the call from my genetic counselor, and she said, "Do you have a few minutes to talk?" And I knew immediately that I had tested positive. And I was emotionless for the first few weeks. At that moment, the emotions just came pouring in. And I was 33 years old. I was a successful attorney. I was a newlywed, and my husband and I were planning on starting a family. And that was all put on hold because we really needed to figure out what was going on, what the BRCA mutation was. There was no Angelina Jolie op-ed. There was very little information and research that I had ever come across other than knowing what my aunt had told me. And so when we wanted to start a family, do we just go ahead and start? Do we do PGD testing, which is where you test the embryos for this mutation? A lot of questions had to be answered before we proceeded. And I remember as I was leaving my sister's house to go back to work, I got into my car and I was crying. And in my mind, it's not if I'm going to get cancer, it's when. And for me, the information was unbelievably overwhelming. But at the same time, it was remarkably empowering.
Wow. Very emotional story. And note to self, never tell a patient, do you have a few minutes to talk? Thank you for sharing that insight, Susan. We need to remember that. So now that we heard how to get tested, what the test means, and how it impacts people, we now turn to Dr. Domchek and say, okay, help us. What can a woman or a man who tests positive do to manage and reduce their risks?
And this is where I hope we'll get into empowerment and how this can be life-saving information, because it is scary to hear, but it's also very empowering. I wanted to follow up on 2 quick points, though, from your story, which is so illustrative. One is that sometimes people don't know anything about their family histories, and it's worth asking. And we make people fill out these annoying forms about family history, but it's amazing what people find out about their family history, because a lot of people just don't know. And sometimes the dad side of the family is a little harder to figure out. So as a reminder, to emphasize for the 3rd time today, 50% of the time if someone has a gene mutation, it came from dad's side. So you really, people have to pay attention to that. And we've had women say, well, I didn't think it could come from dad's side, or my doctor told me I didn't think it should come from dad's side. And it's just not true. And we do actually make phone appointments, by the way, if we're going to do it by phone, because we don't like to have people caught driving down the highway. And also you can spit in a tube. And now you don't even need a needle anymore. So there you go. So we're making some slight progress here. All right. So what do you do? So now you're told this information, and as you've heard, I mean, you don't want to hear this information when you're in your 20s or 30s, and you have a thought in your head of how your life is going to be, and now this adds this wrench to the system. But first of all, these are lifetime risks. They're not risks that are going to happen tomorrow. These are long-term risks, and you're also the same person yesterday that you are today, and that takes a little time to sort of adjust to. But we can work on these risks. So right now we have strategies that can significantly reduce, not eliminate, but significantly reduce the risks for the development of cancers. A lot of these are surgical, and so we're working on other strategies to reduce risk, and we'll talk about that more later. But right now, for breast cancer risk, at the minimum, we do enhanced screening, including breast MRI as well as mammograms. We start at 25, and with that approach, we generally catch cancers at a very, very early stage, and women have an excellent prognosis. There is also always the option, not mandate, option for a prophylactic mastectomy, prophylactic removal of the breast. And that's something that people really need to talk about, with their spouses, their loved ones, their doctors, to figure out, if that's right for them and when. For the ovaries, we have more trouble because we basically have no effective strategy to screen for ovarian cancer, despite people trying. And so there we do have a strong recommendation that women have their ovaries removed. Around 40, there's some wiggle room either way. BRCA2 can be a later, BRCA1 can be a little earlier. And we're working on it. We want to have better early detection strategies, better prevention strategies. For the ovaries right now, the surgical removal is one of the main things that we have to go to. There are also medications that you can take to reduce your risk of breast cancer, and birth control pills reduce the risk of ovarian cancer. So there's a lot to this. I mean, that was the quick, review of medical management. In actuality, it takes a long time to go through with an individual person based on where they are and having their kids and all these different stages of their life. And we try very hard to work through it with them as well.
So before we turn to Danny to talk about how she figured out her decision, Susan, I'm a little bit confused, so therefore I feel like the audience probably is. If I was sitting in your office now and you said to me, okay, your choices are every 6 months to go and undergo surveillance, or we could just lop them both off, how do we determine the risk profile? In other words, Angelina Jolie coming in the news and saying she did this, she lowered her risk from what to what by doing that?
Right. So the Angelina Jolie article was helpful because it got people talking. Okay, and I think that's critically important. But there were a few things that she stated she has an 87% lifetime risk of breast cancer. That is on the very high end, and pretty much that's not the average number that we tell people, because it's way higher. It's sort of the first study ever reported, and it's the highest number that's there. So it's something that we always try to remind people. There's a range here, and the lowest reported risks are as low as 40%. So there's a really wide range in risk. Having a prophylactic mastectomy absolutely decreases your risk substantially by more than 90%, and we view the residual risk of developing breast cancer as about 1% to 2%. So it doesn't completely eliminate it, and people can have complications from breast surgery. They can have chronic pain. They can have trouble with their implants. It doesn't look like them. It can impact sexuality and quality of life. And sometimes it can come across in the media these days as just not that big of a deal, and for some people it's not that big of a deal, but for a lot of people it is. And so it's really important that we kind of work through whether it's the right thing for people and when, and also for women to know that they don't have to do that, and that why don't they have to do it? Why am I so strongly saying you need your ovaries out and given all this wiggle room about the mastectomy? It's because in ovarian cancer we have no effective screening. Most cancers, when they come up at late stage, and most women, unfortunately, with late stage ovarian cancer don't do well. Flip it to breast cancer, where you already heard that 40,000 women a year die of breast cancer, but 240,000 women a year develop breast cancer. So most women survive, and with breast MRIs, most cancers are caught very early, and most women survive their breast cancer. Now, they have to deal with a breast cancer experience, which is unpleasant, right? So I'm not saying that there's, that we're telling people screening's fine, but more that there are these choices, and there's no good evidence that, if you will, if you have a prophylactic mastectomy, that you're going to absolutely live longer than someone who gets diagnosed with an early stage breast cancer, if that makes sense. So it's a subtle point, and one that we explore a lot with people, and why it's important to have a conversation about what the right thing is for you. Also, and I'm sorry, I know I'm going on too long, but just one last point.
That's very helpful.
People change their minds, right? So people can start screening and feel like they're just not ready. You're 26, you're not married, you haven't had your kids yet. It's just not, you just can't imagine having a mastectomy. Fine, we'll screen you. And at some point, down the line, you might be ready for a mastectomy. That's totally fine. And time and time again, studies have shown that when women are in charge of the decision, when they decide what that right timing is, when they feel it's their choice, there's just a much better satisfaction and feeling good about having made that decision. So again, a lot of conversation about sort of what people are concerned about and trying to work through that with them.
Thank you. I think that was really very helpful. It's a powerful statistic for us to understand that prophylactic mastectomy, reducing it down to 1% to 2%, really doesn't improve mortality over early detection and treatment. So that's really reassuring to those of us who have to counsel patients. So really good point. Now I'll turn to Danny and say, okay, so what did you do, and how did you decide what to do?
April 25th, 2010 was the day that I learned that I was positive for this BRCA1 mutation. At the time, as I told you, I was a newlywed, and I wanted to start a family. I was not ready to do any type of surgical prophylactic surgeries. So what I decided to do was research my doctors. I found a wonderful set of doctors. I have a wonderful breast oncologist at Sloan Kettering that I went to see, that I continue to see every 6 months. At which time I get a breast MRI or a mammogram. So every 6 months I'll get one of those imaging. I also have a OBGYN oncologist or GYN oncologist and at NYU, and I get the CA 125, and as Dr. Domchek said, it's not the greatest predictor of ovarian cancer. So I have undergone surveillance for almost 5 years now. And I'm about to have my third child, giving birth in May, and I'm a type A personality, so I know that the date is going to be May of 2015. I'm going in for a full hysterectomy in November of 2015, and I'm going in for a prophylactic double mastectomy in May of 2016. I've made the decisions. For me, going to the hospitals every 6 months and actually really seeing doctors every 3 months is too emotional. It's too overwhelming. I have a routine. I call my sister Michelle right before I go in. I cry to her saying I think I have breast cancer, and then I go to Lululemon and buy whatever I want. And that's my routine every few months. And and I kind of I think that I'll always be monitored simply because my aunt died of primary peritoneal cancer. And I can take out everything I think in my body that I can, such as my ovaries, my uterus, my breasts, but there's still the peritoneal that I have to be monitored for. So I don't think I'll ever be out of the woods, but at least I'll know that I've done everything that I possibly can to reduce my risks.
And just a quick comment on the primary peritoneal, just so everyone knows. So that we talk about ovarian cancer, but the BRCA 1 and 2 carriers are at increased risk for ovarian cancer and fallopian tube cancer, which is, if you remember, it's right next to that. And primary peritoneal cancer is just a cancer that looks like ovarian cancer, but happens starting outside, and it's kind of an embryological remnant. It's kind of confusing why it happens, but it's essentially ovarian cancer without the ovaries involved. And it is true that risk can't be entirely reduced. So even after prophylactic surgery, there still is a residual risk of primary peritoneal cancer. It's not very high, but it is still there.
Okay, so things are really looking up, right? So poor Danny's going to undergo all of this, and then Susan's going to tell her, well, you still have to be screened for other things. So that's what keeps all of us in business. But we appreciate you sharing it with us because, and as Susan was saying, it's such an individual decision. So now, and I think it is empowering, we women really do need to be empowered and do the decision what's best for ourselves, our other half, our children, our parents, our sisters, whatever else. So now let's get to a little bit of the practicality of it, Amanda. Tell us a little bit about what's involved in it. Is genetic counseling and Baraka testing covered by our health insurance? How do people ask for the test? When do they know how to ask for it? Take us through it.
All right. So yes, most genetic counseling and testing is covered by major insurance companies, and it's come a long way than where it was when we first started doing BRCA testing in the mid-90s. So when we, particularly for families who are high risk, so there are multiple relatives in the family, anyone who's Ashkenazi Jewish descent, these are all factors that insurance companies take into account when they're looking at criteria about whether or not testing would be covered. When we're talking about doing testing for the 3 common Ashkenazi Jewish founder mutations, that test is going to range between about $500 and $600 if someone were to pay out of pocket for that test, for example. And many insurances are going to cover that cost of that test, especially if there's a mutation in the family already that's been identified. So we really walk through, and I spend about an hour per patient during that initial appointment talking through these genes, these cancerous screening management, sort of what we've covered today, and really explore where people might think or stand on some of these issues and answer questions as needed. So we really feel kind of upfront counseling, which is hopefully covered by most people's insurance companies and has been if we look at it over time. And the testing, we have not had major issues getting that covered, including Medicare. So a lot of people will ask that question. So if a woman's affected with breast or ovarian cancer and they're Ashkenazi Jewish, Medicare will cover cost of testing. The difference with Medicare is that if someone does not have cancer, they will not cover the testing. So that would be an issue of, so, yeah, see people kind of react, oh my God, really? Yes. And so that is an issue that we do encounter when we order testing for Medicare patients, but if someone has had a cancer history, they are covering the testing with no cost to the patient.
It's interesting, before we go on, I'm a little confused, and therefore probably a lot of other people are. Maybe Susan, you could talk us through, when Amanda brings up Medicare, I think, okay, Medicare by definition means postmenopausal breast cancer or ovarian. So I'm thinking BRCA mutation's much more common in young women. And so what happens when you are postmenopausal? Is it still worthwhile being tested for?
It's a great question. So a few things. Most ovarian cancers, even in BRCA 1 and 2 positive women, occur in postmenopausal women. So that still remains true. And any Jewish woman with breast cancer qualifies for BRCA 1 and 2 testing regardless of their age of onset. BRCA 2 particularly can have later ages of onset, so we really have no threshold to test. If you're Jewish and you have breast and ovarian cancer, you can get tested and it'll be covered. So it's a very easy sort of thing to think about. Now it's true that if you're 70 and just diagnosed with breast cancer and have no family history, you're unlikely to be positive. But where we started was that 1 in 40 women who are of Jewish descent will be positive anyway. So it's just sort of always worth considering. Now, another fact that comes up all the time is that we'll have women who their daughters have earlier onset breast cancer, and now this woman is their mom is in their 70s, and they're like, I don't need to get that testing done. I'm not going to take my breasts off, kind of attitude. And we're like, but you can get ovarian cancer. And it's still a real risk. In fact, I just had a woman who I saw when she was 80 and had never had a breast cancer, but was found to have a BRCA mutation that was in her family. Tried to convince her to get her ovaries out. She poo-pooed me and told me, oh, she doesn't need to do that. And at 83, she now has ovarian cancer. So it is really relevant. And again, we can tell you sort of what those risks are, but the fact of the matter is, if there's a family history, don't think you're too old to get tested.
Okay, great. Never too old for that. So now the flip side, Susan. What happens if we test negative but have a strong family history? Where do we go from there?
I'm so glad this question is on the list because it's critically important. We spend so much of our time talking about BRCA 1 and BRCA 2, but we know that there's lots and lots of families out there, particularly with a lot of breast cancer and no ovarian cancer, where we don't find a BRCA 1 or 2 mutation. And we don't know exactly what the cause of the cancer is. So the number one thing up front is that you always have to talk to people about your family history. If there's a BRCA 1 or 2 mutation in the family, then we can say that the people who test negative are at much lower risk. But if we don't find it, then we manage everybody as if they're at increased risk. There are other genes, and I think we're going to get into this a little bit more, but there are other genes that are out there. We know a lot less about them. There's a few that we know a lot about, but are exceedingly rare and are usually seen only in the setting of what we call a syndrome, some very specific other things that we find in families that are extremely unusual. And by the way, it's the point of seeing someone who has expertise in looking for genetic syndromes, because we sometimes kind of come across something like, well, we would also test for this gene because of the way your family looks. But there's a lot of genes out there that only increase the risk by a little bit, and we right now don't know exactly how to use that information. So long story short, we will have people come back and they have breast cancer at 40 and they test negative and they say, oh, that's great. Now my kids don't have to worry. And we nicely have to say, well, it's not quite that straightforward. And so a negative test result is only informative if we know that there's already a BRCA 1 or 2 mutation in the family. Otherwise, we factor the family history into our counseling about what type of screening people should get.
Okay, thanks. So now that we've heard a little bit about the background, and we had Danny so eloquently tell us about her team of doctors, even though we doctors like to believe we are the support network, we know we are not.
We know better.
And so we know that all along this process of making this decision or getting a diagnosis, each individual person needs their own support network. So tell us a little bit about who you've tapped into and how you got through this whole thing.
first and foremost, it's family and your close friends. They have been an unbelievable support to me. My two sisters, we all tested at the same time, and my two sisters tested negative. Thank God. If I were, if anyone in my family were to test positive, I'm glad it was me, because of course you never want to see family members going through anything. But my two sisters have been amazing. My husband has been such an incredible support, but above and beyond family and friends, because you know that your family and friends are always going to be there for you. You can talk to them about anything. I actually became very close friends with another woman who was BRCA2 positive, and it's just a common bond that you share. And together I introduced her to Force, which is an organization. It's called Facing Our Risk of Cancer Empowered, and it's an organization that empowers women to make the appropriate decisions for themselves, and whether that's surveillance or monitoring or prophylactic surgeries. I go to a monthly support group in New York City with various women. A lot of the same faces attend each month, and there are new faces every month as well. I know there's a support group, a Force group in New Jersey. I think they meet in Montclair. But I think for me, attending these meetings on a monthly basis are so important. Yes, they are emotionally and physically draining. I leave with an absolute headache. If I'm not pregnant, I go out for drinks with my friends afterwards. But it definitely has provided me with information that is necessary with different doctors, because you're going to have a whole new slew of doctors to perform the surgeries than the doctors that actually do the monitoring and the surveillance programs. So I would say, family and friends. I would say friends who are in a similar situation, and then of course Force, and those are the support networks that I've tapped into.
Well, thank you for sharing it, because I think it's important for all of us to know there's so much in the media. I'm a big part of the media, so I'm responsible for getting the word out about a lot of medical conditions, and there's so much in the media that's not really based in true fact, and these type of support networks that have really the facts to get out there from the women who really need the facts, these are really important things. And so, I think that's great. I think all of us need whatever support we can get, but I think, any support group, it's always good to have someone who's going through the same thing that you're going through, because even myself, up until this year, I would say to a patient, oh, a breast MRI, that's no big deal. Well, guess what? I had my first one this year. It's not great. It's just not great. I was in there for like 2 seconds. I thought I was going to be pushing the emergency buzzer to get out. I survived. It was fine. But so until we go through it, we're not as supportive as somebody else who has gone through it and tells you what to do and what not to do. So we appreciate that. So Susan, tell us how you talk to other family members and children, and how we should talk to them about Baraka and what's involved in all that.
Yeah, so this is a really critical point, which is that when an individual in a family has been identified with a BRCA1 and 2 mutation, or 2 mutation, we have the potential to impact an entire family. And in fact, the way we think of it in our end is that we're not really testing individuals, we're always testing families. And it's always going to have a ripple effect through a family. And we try to kind of get at that up front. And one of the things we try to get at when, for instance, siblings are being tested is, it's actually not so easy. It's usual that when we test siblings that there's going to be what we call discordant results. Somebody's going to be positive and some going to be negative. And you know what? That can sometimes not be so easy, including for the one that tests negative, because there can sort of be a lot of guilt and all sorts of things that are involved. So it's complicated. It's tricky. These are your loved ones. You're dealing with sort of difficult issues. And sometimes it's really hard to reach out to family members that you don't know very well, right? And you're trying to sort of spread the news, but at the same time, nobody really wants to listen. So what we've tried to do to help families is, one, just talk through them with it. I'll get to kids in a minute, by the way, but these are just adult family members. Talk through some opportunities. we actually make ourselves available so that if family members want to call that are uncertain about testing, we will always happily talk to anybody. We have a family letter template that we give people that's in a Word document that they can modify so that they can send it out to their family members and not have to have maybe a face-to-face conversation, but provide information that way. We have a website, others have websites. We can point them in the direction to Force, Bright Pink, lots of different organizations. But mostly, for me, I think it's about just trying to get those family members in so we can talk to them. A lot of people, the other point about Angelina Jolie is because she was so strong about her mastectomy, we have had some people actually scared off about testing because they think that's their only choice. So we have to be careful, right? Because mostly we want people to be able to have informed decisions, and we'd much rather be doing MRI on people than nothing. And even if people don't want to be tested, we'll start screening if we know there is a mutation in the family. So that's that piece. In terms of talking to kids, this can be tricky. We actually have a woman that we work with, Angela Bradbury at the University of Pennsylvania. This is a specific research focus of hers. We have a lot of information out there. If you're diagnosed with breast cancer, for instance, there's all sorts of books about what age and what you tell your kid and all this kind of stuff. And there's really nothing equivalent right now in genetics. I mean, there's some suggestions, but there's not that kind of evidence-based work. We have found anecdotally that kids know a lot about genetics these days because they learn about it all through school. So they're a little less put off than you might think, and they do view it as empowering. But there are some really anxious kids, and there are some not anxious kids, and it is, has to be taken into account. We, in general, do genetic testing at around 25. There's always specific circumstances that would, change that age, but 25 is generally when we start breast MRI screening. So sometimes women know about a lot about this beforehand, and others not. But it is one of these things that when we sometimes see 18-year-olds. Not infrequently, and we really do talk through with them as if, do they really want to know this information right now? If we're not going to screen till 25, do they really want to have that information at this moment? And as you can imagine, for some people, that would just be an anxiety-provoking thing to have over their head and not really be doing anything about, while they're in college and potentially, exploring their sexuality for the first time. So these are all the things that we tried to talk through. So I can't give specific things except that we do have a lot of advice depending on the situation.
Before we talk a little bit to Amanda about how all of us would find a genetic counselor and what to do, I think probably a large percentage of this room is thinking, Susan, we keep throwing around breast MRIs, and we keep saying these words, breast MRIs, and I would bet that 3/4 of this room is screened by mammogram only. So I can see everyone starting to break out into a sweat thinking that so if you could just diverge for a minute and just give us a little.
As a reminder, although mammograms get a bad rap, they actually do a pretty good job. And particularly, there's all these iterative improvements to mammograms, and slowly tomosynthesis or 3D mammograms will probably take over the world. Not because they're sort of so much better, but they're a little better. And this is sort of the way that digital technology was a little better than film, things like that. So mammograms continue to be tweaked and improved and are still the modality that's been shown to decrease mortality from breast cancer. So despite all the fuss, I still am a believer in mammograms. MRIs are really indicated for women who are at significantly increased risk for breast cancer. And the way that at least the American Cancer Society defines that is greater than a 20% lifetime risk for developing breast cancer. And most women are not in that category. But if you are, a breast MRI is done in the following way. You get an IV, you're in an MRI machine, you're lying face down, your breasts are kind of hanging through the machine and slightly squished. So it's like not the most comfortable thing on the face of the earth, and if you're claustrophobic, it can be a problem. Most people can get through them, but we do warn people, like, it's not, and it takes usually 20 to 25 minutes, and it's somewhat unpleasant, and there are false positives associated with them as well. So if you're not getting a breast MRI, don't feel like you should be, but it's individualized, like who should get them.
Thank you for that, and I think that's an important point. When we get to take-home points, that will be an important point for all of us, all of you, to go back to your internist, your gynecologist, your breast doctors, whoever, and have this conversation, because the literature is forever evolving on this topic as we speak. So Amanda, tell us a little bit what steps an individual should take if they're interested in pursuing genetic counseling. How do you find one? And what happens if we don't know much about our family history?
Great question. So I always say start with your physician, someone who you've been followed by for a long time, and have a conversation. Do you think that this is a warranted referral? And how might I go about getting in contact with a counselor? They might have some resources. Another place that's a really wonderful tool, because you can use it across the country, is the National Society of Genetic Counselors website. And you can find that at nsgc.org. And what you're able to do is put in your zip code and then what type of counselor you want to find. Someone specialized in cancer is really what we're talking about here. And they will be able to list your local genetic counselors in that area with contact information to set up appointments. Most major academic or cancer centers are going to have genetic counselors available for testing. There might not be as many in every community setting of a breast surgeon or an oncologist's office, but they will have resources to send you somewhere. Worst case scenario, you can go to our BASR website, and we're happy to direct you and find a counselor in someone's local area.
Great, thank you very much. And it kind of brings us to a point in the program that we are in a synagogue. This is an Ashkenazi Jewish problem. And now I'm going to turn to Danny and say, what can we as a Jewish community help out? What can we do about Baraka, getting the word out, etc.? How can we help?
I think this is the exact program that the Ashkenazi Jewish communities need. I think this type of panel and education needs to be in every synagogue throughout the country. Like I said, I had no idea what BRCA was when I got my test results back. And over the years, I've done a lot of research. The Basser Center website has a lot of information on it. Force has a lot of information. And I think that what the Jewish community is doing now is really trying to raise awareness, and that is so important because if 1 in 40 Ashkenazi Jews are positive for this mutation, and there are more than 40 women in this room, and so it's always great to be educated and to go back to your healthcare providers and to have the serious conversation. And who knows, maybe someone wouldn't have done that had they not attended something like this. And so I truly believe that synagogues, temples, shuls, any type of Jewish modality throughout the country should really be holding educational seminars and panels such as this one.
Yeah, we thank our temple for providing this because it is another forum to get the truth out. So again, Rabbi Perlman, thank you, because this really kind of helps all of us, and each one of you will be sent home with a mission to inform a lot of other people in your family and in the community what you've learned here this morning. So that kind of leads us to the media talking a lot about population testing of Baraka genes. If you haven't read about it, you'll begin to read about it. And there are definite arguments for and against doing population testing. And I think, Susan, maybe you can tell us the pros and cons of doing it.
Sure, and I wanted to also just remind everyone that there is a precedent to this. Tay-Sachs was sort of, if you will, population-based screening for Tay-Sachs occurred really because the Jewish community sort of embraced that and helped move that forward. And now, any Jewish woman of childbearing age and seeing an OBGYN, they talk to about Tay-Sachs and Tay-Sachs screening. So the question then becomes, well, why don't we do that for BRCA 1 and 2? Why aren't we doing that? And it's a little complicated, so let me take you through some of the things. One of the kind of obvious first thoughts is, hey, if they're talking to me at 26 about Tay-Sachs in the prenatal genetic setting, why aren't they talking to me about BRCA 1 and 2 right that moment? And this is where it gets a little complicated because Tay-Sachs is what we call recessive. You need a bad copy from mom and you need a bad copy from dad, okay? And so, if you will, there's ways to sort of establish the likelihood that a couple will have a baby with Tay-Sachs. But if you have a BRCA1 mutation, you have, if you will, the quote-unquote problem, right? You have an elevated risk. And so if you don't do that sort of, and there has been concern, particularly in the Orthodox community, and I'm not Orthodox, so I apologize if I say this a little wrong, but there's concerns in the Orthodox community that if an unwed woman is known to have a BRCA1 or BRCA2 mutation, that may make her marriage prospects more challenging. So it's layered, right? So we don't want this to be seen as a stain or a stigma. And in addition, the feeling was just to keep reproductive genetics out of this kind of autosomal dominant adult onset disorder genetics. Okay, so that was from the reproductive people. They didn't really want to touch that. On the other hand, we saw someone a few years ago who had, and PGD came up, so I'm going to describe that in a little bit more detail, but we had a woman who had been screened for all the quote-unquote Jewish diseases, recessive, but not BRCA1 and 2. She had a very strong family history, and they didn't ask her anything about it. She had in vitro fertilization, that's the way she needed to get pregnant, and then later was found to have breast cancer and found to have a BRCA1 mutation, and she's like, I would have done, when I had my IVF, I would have screened the embryos and only reimplanted the embryos that didn't have the mutation. Why did no one talk to me about that then? So it's complicated because of these issues. It's also complicated because if you start doing real population screening, so far we really haven't done that. We've tested women who have a family history, right? No, women or men who have a family history. When you start doing population screening, we know that sometimes a woman's risk for breast cancer having a BRCA2 mutation might be as low as 30% or as high as 70%. And it's probably lower if you have a big family with no cancer. So should we be rushing to prophylactic mastectomy to them? What are really the risks if you have no family history of cancer? So we're still establishing that. And finally, on my end, I think it's important, and we're putting together research in this realm. We have to figure out how to do this so people are informed before they're testing. Imagine if you had your test sent and you didn't know anything about it, and then all of a sudden at 25 someone came back to you and said, that test that we talked about for 3 seconds, you have to get your breasts off and your ovaries out, right? That's not what we want to do. People have to sort of decide when it's the right time for them to get tested, and we need to do that in an informed way. I think it's possible, it's just not, it's just challenging. And then finally, in the US, most people aren't Jewish, and most doctors out sort of in Nebraska don't ask their patients if they're of Ashkenazi descent. So we actually have to way of figuring out who is, because the testing, the cost of the differential in the testing, it's $300 versus, or $400 versus $4,000. This is a tenfold cost. I mean, we could bankrupt the medical system by sending the wrong tests. And conversely, if you don't send the right test, you can miss things. So it's nuanced. But I do think that we've always said we have an extraordinarily low threshold to send a test to anyone who's of Jewish descent. If people come in and they're Jewish and they went testing, we send it. So I mean, just to make it clear. But population screening has a different thing. Population-based screening means that every Jewish person in the internal medicine practice is basically sent that test with virtually no sort of discussion ahead of time. And that just might be a little harder. So we have to figure out how to do it well and correctly, not hurt people and help people.
I think that's a really good point. I could not imagine screening my entire practice and then having to deal with that and the impact of it. So I think that is something that's probably going to evolve.
Yes.
And as we kind of piggyback that, Amanda, the genetic testing field is evolving. And so if someone has already been tested for the Baraka gene, and there's all these new things coming out with other genetic mutations, what do you recommend?
For an individual who has a known mutation in their family, we really don't go beyond that. That's really the driving force in terms of their increased risk of breast and ovarian cancer in that family. As we have learned, BRCA1 and 2 are not the only genes that increase risk for cancer, and there are others, but they're much more rare when we compare them to BRCA1 and 2. So we look at family history information. And so for some people who have tested negative for BRCA1 and 2, they've had cancer, let's say, but still have a family history that we're trying to figure out. There are some other genes that we can look at, and Susan had discussed this earlier. And so what we really do is let the family history tell us a little bit more how likely some of these other genes might be explaining the cancer risk in the family. With the advent of technology advancing very fast, it also allows us to test for multiple genes on what's called a panel test, and so we can look at 20, 30, and there are panels that are huge. But we have to understand that a lot of these genes on these panels that are being tested, we don't really have much information about how that's going to impact long-term cancer risk, screening management, decision making, and so we have really kind of been hesitant to jump forward in testing multiple genes that we're going to say, I don't really know what to do with this now, good luck. See you in a year. So we really are wanting to test appropriate people and appropriate families for the genes that we think are most likely. Let's learn a little bit more about some of these other genes before we start kind of doing a wide mass testing for them. So I think that's where it stands. So certainly we'll probably have other genes in the future, but we're still learning what's the long-term impact for that patient and family.
Okay, I think that's helpful. I think what would be helpful for all of us now is to know what the current research is out there for BRCA carriers, and what do you see in the next 5 to 10 years? I mean, how can you kind of help us put it all together?
Yeah, the exciting stuff, what we're going to do differently and better. And this is just a small point before I start on that. We focus a lot on breast and ovarian cancer, but I do want to remind everyone that there are other risks and risks to men. So there's a risk for male breast cancer. There's a risk of prostate cancer. Those are particularly for BRCA2 mutation carriers. And there's also a small increased risk of melanoma and pancreatic cancer in BRCA2 mutation carriers. So we look at all those things. And so I'm happy to take more of those questions sort of after the program. So what are we doing research-wise? So I think that what we would like to do is prevent cancers non-surgically. This is the ultimate goal. The fact that we are taking off people's breasts and taking their ovaries off and putting them in premature menopause, I mean, really, we should be able to do better than this, right? They are effective strategies, which is why we're using them, but at the same time, we can't sort of, rest on our laurels and say that, this is acceptable. We absolutely need to do better. So in that realm, there's a few different things. One is that we are investigating drugs that could be specifically used for BRCA1 and 2 mutation carriers. And extremely excitingly, one of the first drugs specific to BRCA1 and 2 was approved. It's a drug called olaparib. It's approved for the use in a very advanced ovarian cancer in BRCA1 and 2 mutation carriers. And it's a drug called the PARP inhibitor. And that drug is now working its way through sort of the pipeline. We've been very involved in that work, so it's been very exciting. But we're working our way through the pipeline of using it in earlier and earlier settings. And there is a theoretical possibility that it could be used in a prevention setting, maybe taking it a month a year. Now, that's way in the future, but it's not crazy, and it's not pie in the sky, and there's actually a potential drug. Okay, so that's one class, is chemo prevention. We call it chemo, it's not really chemotherapy, chemo meaning drugs, so drug prevention. A second area of really active research is in immunology. So many drugs that have been approved in oncology lately are immunology drugs. I mean, my husband's an immunology oncologist, and as he puts it, this was the 20-year overnight success story, which is, people have been like working at this forever. Everyone kind of laughed at them and said, yeah, immunology and cancer, what are you guys, crazy? And now, one drug after the other is being approved in diseases that you couldn't think of before, including activity of an immunology drug against lung cancer, which, who thought that could be the case? So there's an interest in trying to take the person's immune system and use it to attack cancers at their earliest stages. So interest in sort of vaccine development and other immunologic strategies. And again, that's going to take a while, but there are active studies ongoing now. A vaccine study just started first in cancer patients at Penn. Other groups are doing work like that. So very, very exciting work. And then finally, I could go on all day, but I know you don't want me to. We are really interested in trying to figure out, as for an individual, what is your risk? And why is that important? It's important because I would love to say to someone, you can take your ovaries out at 50, be spared early menopause, and still not get ovarian cancer, right? Because that would be the best of all possible worlds. Right now, we know that early menopause can do harm too, and certainly can make people have symptoms in terms of quality of life. So we're doing that by virtue of what we call other genetic factors, genetic modifiers, and other types of modifying factors. And we are really hopeful that someday we'll be able to integrate all this information and provide more information for a specific person in front of us. And that will also aid us in population-based screening. Because as you said, we're going to get to population screening. For me, it's about implementation. It's about how to do it right, and not harm people along the way. But we will be looking to work with the Jewish community to get that right.
Thank you. So I think it's really very exciting for those of us in the medical field and those of us not in the medical field to know that the field is forever evolving for the better, so that decisions like Danny's will get easier and easier because there'll be more options. So before we kind of get a take-home message from each of our panelists, I'd like to remind you that we are going to open this up. So if you wrote down your questions, Debbie will come around and collect them, and then when we finish with our take-home message in a few minutes, if you didn't write down a question but you want to stand up and ask a question, that's fine with us too. I'll collect all the cards. I kind of think this will help with duplication of questions and kind of keep things streamlined. So I just wanted to kind of remind you of that. If you want to write something down now, just kind of wave your card, and Rabbi Perlman or Debbie Klein will collect it for you, and we can then kind of wrap things up and get to what you really want to know. I can see people want to know a lot of things. So do you guys, do you care who starts, what your messages are? We'll start, maybe we'll just go down the panel, whatever. I mean,
We'll adjust accordingly.
yeah, because I think that
Yeah.
we're going to have a lot of questions now.
Yeah.
So why I kind of looked through all of your questions, if you would give your attention, I'm sorry?
If we wanted to ask something, let's say something you wanted to ask her.
Yes, in a few minutes, we will open it up to the floor. Let me just let our panelists who have been so dedicated to educating you, give you, I know in my own office, after an hour with a patient and their head is like spinning, Dr. Simpkins said this, Dr. Simpkins said that, I say at the end, listen, here's the 3 things you need to know. Forget about all these other things I told you. So like you have to get a mammogram, you have to get a colonoscopy, and you have to get a pap smear. I'll see you next year. So like we all just want to take home message. This is a fast society. Don't tell me my cholesterol. What am I going to do to stay alive till next year when I see you? So that's it. So we're going to let our panelists give you their take-home message, and this way you can kind of crystallize in your brain, so you will be smarter than when you walked in here this morning. So Amanda, if you want to start.
All right. I'm going to touch on the importance of family history. When you're having holidays and you're together as a big family, ask, what did Aunt so-and-so have again? And write it down. Ask sort of some of the questions that you wouldn't normally have asked, and write it down. Come to a genetic counselor, and even if you don't have all the details, we'll be able to work with you and talk it through. And our main goal here is testing is covered by insurance. It can give valuable information to determine risk status and to help you make decisions. So that's kind of my message here.
And mine is that genetic information can be empowering, and it puts decision-making in your hands. So try not to be scared of it. Come and get tested, and then you can do what you want with that information.
And mine is life goes on after a positive result.
Yeah.
Life goes on. You continue your daily activities. You get married. You have your children. You make the decisions that are right for you. Feel empowered and enjoy your life, because luckily we have the information that we can use to our benefit.
Well, I think those were great take-home messages. Now, I'm just going to say, in a room of predominantly Jewish people who are not shy. We are going to pass the microphone and you can ask questions. But remember, your questions really need to be something that all of us can learn from. If you have specific questions for any of our panelists, they'd be more than happy to answer them for you afterwards, or refer you, or let you talk with them. But please do not give us your specific scenario or a question about someone specific in your family, because they're not your treating physicians. I just want to remind you of that. But anything that you think would be relevant that we could help with, there's a very good question here that I think is kind of off topic but interesting to myself, and I think we could address it. Someone asked about birth control pills, and the thing that I think is so interesting is you heard that Dr. Domchek mentioned that birth control pills are preventative for ovarian cancer. But somewhere out here, somebody told us they increase our risk of breast cancer. So could we talk a little bit about that?
Sure. Alas, medical information is rarely able to be put into a soundbite, and I think this is an example, which is that oral contraceptive pills, like every medication, have both risks and benefits. And that risk-benefit analysis has to be taken into account every time you see someone. So what are the benefits of birth control? Well, they prevent unintended pregnancy, which is astonishing in our country how much of that there is. So that's, a start, which is, it is valuable. Now, there are other ways to do birth control, but it is a issue that I am asked pretty much on a daily basis in clinic about people's teenage daughters. And, in the end of the day, I think, would you want your 17-year-old pregnant? So you have to think about this in a realistic way. So that's a plus. It can control cycles when people have really irregular cycles or heavy bleeding and things like that. It can also cause blood clots, right? And something that we don't talk about all the time, but we in oncology talk about all the time, which is that there's an increased risk of blood clots. And on the cancer end, there's a significant decreased risk in ovarian cancer, and there's a possible slight increased risk of breast cancer while people are currently using medication. In mutation carriers, the data is actually not crystal clear. If there is an increased risk, it's small. So our take on this is that we're somewhat agnostic. So we say, if you would like to take birth control pills for the other reasons that you would take them in your life, go ahead. But we don't say take them just to decrease ovarian cancer risk, because if we know someone's a carrier, we're going to be nagging them about getting their ovaries out. So that's not necessarily in itself a good reason to take them. I don't know if you have other comments.
Well, the only other comment I have is this week's news about brain tumors and breast cancer, brain tumors and birth control pills. Those of you who read the New York Times or the Wall Street Journal, it made front page news. Forget the study. It was 300 people in Denmark. Forget the study. Gliomas are very rare. We know that they are deadly. People, when they hear the word brain tumor, they say, oh my God, I'll stop taking my pills. That is not what we doctors want you to do. So all those kind of questions go back to your doctor. The risk-benefit ratio, very good question. Now, there are multiple cards here, Danny, about peritoneal cancer. Let me just say, as a non-oncologist, as a practicing doctor for 27 years, I have had one case, okay? So there's a lot of cards saying, how do we screen for it? Do we have to worry about it? What is it? It was mentioned, it is a real risk because it's in Danny's family, she's conscious of it. But could you just tell us a little bit about the rarity of peritoneal cancer?
Yes, so it is a very rare cancer, and it is not one that should keep you up at night, as easy as it is for me to say that. So even in families with primary peritoneal cancer, there isn't really evidence that it runs in families, if that makes sense. So but it is in that spectrum of ovarian, fallopian tube, and primary peritoneal cancer. We don't even know if it's really a single cell that flicked off from the ovary at some point when the ovary developed cancer, and then it just kind of manifested along the wall of the lining of the abdominal cavity, which is what it is. The peritoneum is just the abdominal cavity, and a peritoneal cancer is basically a cancer of the lining of the cavity. But we do know that in women who have BRCA1 and 2 mutations, if they have their ovaries removed, they massively reduce their risk of developing ovarian cancer / fallopian tube cancer / primary peritoneal cancer. And the residual risk is for BRCA1 in the 2 to 4% range, and for the BRCA2, like 1% or less. So that puts people in about the same range as the average person's risk for ovarian cancer. And let me tell you, it's extremely unsettling, and when it happens, it's awful because it can happen to people who've had their ovaries out anyway. But this is when I sometimes, in my oncology life, seeing cancer patients, I say, like, every day you get in the car and you know you can get in a car accident, but what you do is you buckle your seatbelt and you're careful and you did what you could. And there's an element of that, which is that you did what you could. And although you can do CA-125s for primary peritoneal cancer, it's not entirely clear how helpful that can be. So what I try to do is just emphasize to folks, and I don't know if it's helpful, that it doesn't happen very often. But again, that's still not helpful in a family where it occurs. So you may have more comments on that. Yeah, I mean, it's hard.
Yeah, I mean, I think that for me, I know that, my dad's sister had it, and she subsequently passed away 2 years after her diagnosis. So, I do plan on getting everything out that I possibly can, but I also know that for the rest of my life, I will be screened and monitored, and I still will undergo surveillance. So it's just, it's a fact of life. But I know that I'm reducing my risk significantly. I'd love to have the same percentages as the general population. I'm looking forward to those days in the next couple of years. So.
Yeah, I think the more knowledge we have, the more power we have, and I think all of us wear some albatross around our neck, and the more that we can take it off by knowledge, the better we will be, because as Dr. Domchek said, and as all of us know, I mean, if you have a father who dropped dead at 40 of sudden death, your risk of dying of heart disease is a lot higher than mine. You have to wear that albatross every day. I have to let you go about your life and exercise and do all the things that you should be doing anyway. So what we're doing here today is trying to separate out fact from fiction. We know some of the news is ominous and makes people unnerved, but at the end of the day, I think what we're doing here is educating all of us that there are a lot of things we can do. The one thing that we didn't touch on that there's some questions about is if a man tests positive for Baraka gene, what is their screening?
So, so I'm going to go through that, but I will say that they're made up recommendations because we really don't have the same evidence base in men that we do in women, and that's unfortunate. We're all working on it. So their sort of expert guidelines suggest the following. Whenever you hear that, you can say made up on the basis of best guess. The risks to men are lower. They're higher for BRCA2 mutation carriers, where the lifetime risk of male breast cancer is about 5 to 10%. The lifetime risk of prostate cancer is as high as 25%, but that prostate cancer can actually is usually a much more aggressive prostate cancer. So this isn't really the prostate cancer you hear about in the news that people sort of die with, not of. This is a more aggressive form of prostate cancer. And again, these small risks of pancreatic cancer and melanoma. So for men, and then a major reason to do testing in men is, and now you've heard this brought up a couple of times, is pre-implantation genetic diagnostics. So if you're like a 32-year-old man, you just got married, you want to have kids, and you're interested in using this information for reproductive purposes, that can be very helpful. By the way, although some people do PGD, a lot of people don't. I mean, it's going through PGD is a lot more expensive and a lot less fun way to get pregnant. So, so it's just, it's an option that's available, but it's, absolutely just an option. So for men at 40, we do a baseline mammogram. For some men, they really have no breast tissue, so the value of doing repeat mammograms can be low. We offer sort of repeat mammograms, but literally the recommendations say consider baseline mammogram and consider follow-up mammograms. It's ridiculous. Self-breast exams, mostly letting men know that they can get breast cancer, and because a lot of men don't even think that that's possible. We do recommend PSA screening starting at 40. Again, kind of that's this enhanced compared to the general population. And melanoma, look at your skin, so that's easy. See a dermatologist. Pancreatic cancer screening is very debatable. There's ongoing studies right now about using something called endoscopic ultrasound. This is for both men and women. And the current studies enroll BRCA carriers that also have a family history of pancreatic cancer. So there's a lot of interest in trying to figure out whether pancreatic cancer screening works, but we're really not sure at this time. So again, we very much hope, apologies to the men in the audience, we are working on more specific guidelines for men, but that's what we've got right now.
Okay, so before we open it up to the floor to anyone who has something they really would like to say, I think that's come across in these cards, and that's something medically very of interest to me, is there correlation with all of the current studies on breast density and Baraka screening, and do they go hand in hand, and do they influence any decisions in terms of what someone would do based on their breast density, which is all over the media now?
Such great questions, and I feel like I'm being a microphone hog, but then I will stop. So it turns out that within BRCA 1 and 2 carriers, breast density doesn't really add a lot to the equation because the risks are already high. And MRI kind of sweeps away breast density for the most part. Breast density makes it harder to interpret mammograms, but it really doesn't have a significant impact on breast MRI. So really this issue of breast density, and I forget if New Jersey also has a law, the notification law. So these breast density notification laws have been put into place in multiple states where if you do have dense breasts on your mammograms, you get this rather ridiculous paragraph talking about, risk and all this stuff. My sister, who is, we like to call her a stay-at-home lawyer, sent me a copy of it and said, "What on earth is this?" when she just got her mammogram. She's like, "Who on earth wrote this?" I'm like, "A lawyer did. Your fault." But basically, it suggests that women could consider additional screening. The problem is that it's not mandated in the states that the insurance pay for any additional screening. So let's take a step back. What does it mean to have dense breast tissues? Again, this is in non-BRCA 1 and 2 carriers. It makes the mammograms a little harder to read, and it in itself is a modest risk factor for breast cancer. But by the way they characterize it, 50% of people have this. So it's not like a massive risk factor, it's a modest one. So you can do ultrasounds, but again, screening ultrasound isn't generally paid for and in a lot of places not offered. You can get an MRI, but really your insurance is only going to pay for that if you have an elevated risk. So they're doing these new technologies like 3D mammography and everything is trying to get around the density issues. But we're in this really weird conundrum where women are told they have dense breast tissues, but then like, hey, that's nice. See you later. And I find that odd.
Right. I think in the state of New Jersey, as of June, yes, Rosemary, as of last June, as of May, it is law, so we have to notify you that you have, normally dense breasts, heterogeneously dense breasts, or extremely dense breasts. And since you did not all go to medical school, but you get this letter in the mail, you throw your hands up. So what I say to all of you as a take-home message about density unrelated to Baraka testing, that is why you have a doctor. The doctor who signed that prescription for you to get that mammogram needs a phone call from you saying, what is my next step? We will then assess what we think your best next step is as of January 2015, because by February those recommendations might change. But this is unrelated. I'm glad that we hear that there's really no relationship to BRCA gene mutation, because that always floats around in my head because patients ask that all the time about density of breast because it's a hot topic. So I think that's a good take-home point too, that you are not supposed to be understanding heterogeneously dense breasts. And to me, I thought like if you had extremely dense, it sounded kind of good. Like, oh, I don't have a lot of fat. Oh, bad. Better to have fat in your breast, FYI. Okay, so let's open up the floor to anyone who has anything they want to ask before we conclude or say. Okay.
Yeah, I just want to mention, and a lot of it was covered. I've been living with ovarian cancer for 7 years, did not find out I was BRCA1 positive till after, when we did extra research about family, because my parents' age and grandparents didn't talk about it. And so it's crucial to ask those questions now of your parents and your grandparents. One of the things that didn't come up was the internet. Be careful what you look at and what you read on the internet. There's some great sites. There are also some not so great sites that you need, that you should be wary of. People in the situation force, Danny, I also used force when I first found out I was BRCA positive. There's some great things out there, but just don't do Google searches and read everything you read. It's not necessarily beneficial to you. And there's so much research going on out there. I actually did an olaparib clinical trial. Stay educated if you are BRCA positive, and be your own advocate. No matter what's going on in your life, live your life and be your own advocate, because nobody's going to be as concerned about what the issues are and what your life is aside from you. So.
Thank you for that, and thank you for sharing, because I think that is an important takeaway message, that in anything, all you have to do is type it into your iPhone now, and you will have more information than you ever wanted. But as Amanda gave us a great website, we need to go to the websites that will be helpful to us, or to the organizations that will be helpful to us, and not just random information. And I thank you for that, because that's a good point.
Yeah, and on the back of your thing, there's a bunch of websites, including Force and Bright Pink and Vassar.
Perfect.
Hi, I just have a follow-up question to the peritoneal point, even though I understand what you said, Dr. Domchek. When Danny said she's going to continue to get screened, so I also had a oophorectomy and a prophylactic mastectomy. Yep. You know that. You're my doctor. But just for the sake of the room. But I'm still concerned. So when Danny says she's going to do everything but still get screened, how can you still get screened?
Yeah,
how can I still get screened?
Yeah. So if people are desirous of that, we can do CA-125s, and that's again usually if people are concerned about it, I'll talk about it. The challenge with CA-125s is that they're not a perfect test in both directions. They're both not very sensitive, so they're not always high when there's cancer, and they're not very specific, which means they can give us a false positive. So, but again, it's one of these things that I'm fine with it. It's not a specific recommendation right now that people continue to get CA-125s post oophorectomy. So if you're not, don't worry about it. But if people are interested, it's just a blood test. In general, again, we don't do ultrasounds unless people have symptoms. So.
Okay, I think we have time for just a couple more points.
Hi, Danny, I want to thank you for mentioning force, and particularly the force, the Northern New Jersey force, which meets in Montclair, New Jersey. My wife and I are the outreach coordinators for that meeting. And in fact, if anybody is interested, the next meeting is April 12th, which is a Sunday at 2 p.m. at the Montclair Breast Center in Montclair. You're all welcome. Also, I want to remind people that if you don't know about it, there's a force conference in Philadelphia, June 18th, 19th, and 20th, sponsored by BRCA. It's an amazing conference. Over 700 people were there last year, and it's very well worth attending.
Thank you for sharing that. That's very helpful. And I assume if anybody had any questions, they could come see you after. So thank you very much. It's very helpful.
Sorry, on the last question here, not very profound. Do you need a genetic counselor, not to take business away from you? Or could, let's say I just go to the Summit Medical Group and say, can I have this?
Right, that's a very good question.
Because aren't they recommending that all Ashkenazi women do this now, because we have such small, a lot of people nowadays just have small families, and nobody really knows if you have.
Right. So let me answer
family
before the
history.
experts answer. If I sent you for the test and I got the results, then it's up to me to counsel you. And I do not have the knowledge and expertise to counsel you. So that is precisely why we send you to the best people, because it's all information for me as it is information for you. And as you heard from Danny, it's not so easy to take the information, let alone from somebody who is not the top of the food chain in interpreting. So I would say, go ahead, but
Yeah, I have to say that I will sort of speak for all of us when I say that we're all going through an internal angst period about this because we don't have enough genetic counselors to screen everybody. So we're trying to come up with alternative models for this because the key is not necessarily who gives you counseling, but that you get some information before you get tested, if that makes any sense. And there are guidelines for what information should you have. Basic things like what are you being tested for? How much does it cost? And what are the potential pieces of information that I can receive and how it might affect me, right?
Do we all know that kind of now after?
Well, there are. I'm not being not being flippant when I say that these are the types of things that we're trying to work on. Can we do group counseling sessions and then do it? But then the issue is, okay, what's your insurance? Who can I send it to? What will your copay be? And I can tell you that most everyday internal medicine docs don't know exactly how to do that. Some do though. So feel free to talk to your doctor about it. I mean, we're not saying that people can't do it. Any medical provider can order the test. But what we find important, and particularly, I'll be honest with you, in young women who haven't had their kids and all that kind of stuff, it's really important to sort of think through what this impact is going to be on your life before you get tested. So I think that the devil's in the details. Another thing that we're well aware of is that for people with ovarian cancer, for instance, if you're Jewish or with ovarian cancer, you need genetic testing. So do we have to go through a big rigmarole, or can we streamline that and have more of the conversation afterwards? We're working on all that. We're not trying to make it hard to access information, but we also know that people who don't get the appropriate information can actually be hurt, and we've seen that too. So Amanda, do you have?
I just have one last point I want to make too. One of the things we have to remember is not BRCA 1 and 2 mutations do not account for the far majority of people who have a family history of breast cancer. So I'm a little leery sometimes when people are an expert in family histories and doing testing, and that patient walks away saying, yes, I'm negative, I don't have to worry, but they miss the message that they still have a family history and might still warrant from increased surveillance of breast cancer, and that might not be the message that their provider is giving them because their testing came out negative. So that's one of the things that we really try as genetic counselors to really talk through and look at, that we know that BRCA 1 and 2 mutations don't account for most people's family history, and so we always need to evaluate every family individually to give kind of risk assessment and management recommendations. But yes, there are not enough of us.
Right. And we're working on it. I want to emphasize, we're trying to get it so that it's easy for people to do this.
Okay, I know that there's a lot more questions, thoughts, comments that you want to share. Unfortunately, I really have to let my colleagues who have to go back down the turnpike to Philadelphia. So we kind of have to cut this short. On behalf of not only the Temple, but the medical profession and the people who really need the knowledge, i.e. myself, I thank you for all of this knowledge that you have shared with us this morning. It was incredible, and thank you, Danny, for sharing a very emotional story that has a happy ending. And so I think, as my take-home message, I started out by telling you about a young woman who was in a very interesting predicament about not knowing what to do. And after being in here for the last hour or so, I am empowered with much more knowledge, much more options, where she should go, who she should help, what is going to give her the best outcome for a normal, healthy life. So I thank you for all of your time. It's been really enlightening for all of us.
Really been thinking. Dr. Simpkins and Dr. Domchek and Amanda and Danny, and I know that some of you have to go, and that's okay. We have more food if you want to stay and schmooze, and they're here. I want to say one thing is that this program was in a synagogue, and we intentionally so, and so even though your clergy are not medical professionals, we can be spiritual and pastoral presences in your life. So if there are reasons to talk, our doors are always open, our inboxes are always open, and we were really glad that you were here this morning. Thanks, everyone. Have a great day.